The disclosures for guests on this podcast can be found in the show notes.
Hello, and welcome to JCO at ASCO 2026, our series where we cover some of the top JCO papers published simultaneously with their abstract presentation at this year's meeting in Chicago. I'm your host, Dr. Jake New, JCO Editorial Fellow, and I'm joined with Dr. Umang Swami, JCO Associate Editor, to discuss the Journal of Clinical Oncology article and ASCO annual meeting abstract presentation titled Neoadjuvant Sacituzumab Govitecan in Patients with Muscle-Invasive Bladder Cancer, Primary Results of the SURE-01 Trial, Aniche et al. So, Dr. Swami, let's start with the relevance of this article. Can you explain that to our listeners?
Thanks, Dr. New, for having me on this podcast. I will start with the background of the management of muscle-invasive bladder cancer for cisplatin-ineligible patients. Till recently, before the results of the EV-303 trial, the standard of care for management of patients with muscle-invasive bladder cancer who were ineligible or refused cisplatin-based neoadjuvant chemotherapy was upfront radical cystectomy. However, approximately 50% of the patients experienced cancer recurrence within 2 years. The SURE-01 trial evaluated sacituzumab govitecan, an antibody-drug conjugate targeting TROP2, as a neoadjuvant treatment option in this patient population. This is important because antibody-drug conjugates are rapidly reshaping bladder cancer therapy, particularly after the success of enfortumab vedotin plus pembrolizumab in the perioperative setting. Importantly, this study also explores bladder preservation and biomarker-driven treatment selection, which are becoming increasingly important goals in urothelial cancer management.
Very interesting. Okay, so can you walk us through some of the key results and how they might impact practice?
There are several important findings from this study. First, although the trial did not meet its strict protocol-defined primary endpoint of YPT0N0 at cystectomy, the broader post-hoc complete response rate, including patients assessed with repeat TURBT, was nearly 30%. Second, the 24-month event-free survival was approximately 71%, which is encouraging given that many patients had higher risk disease, including clinical T3, T4, tumors, and variant histology. Another interesting finding was that nearly one-third of patients declined cystectomy after treatment, likely because they appeared to achieve strong responses. Notably, at the time of analysis, there were no intravesical recurrences among those patients. From a translational standpoint, the biomarker work was especially compelling. Responses appeared enriched in non-luminal molecular subtypes, and low TOP1 expression was associated with improved event-free survival. Clinically, this study suggests that TROP2-directed therapy may have activity in localized bladder cancer and could eventually contribute to more personalized or bladder-sparing treatment strategies.
Very good. I found those biomarker analyses quite intriguing. Are there outstanding questions that need to be answered?
Absolutely. Several important questions remain. First, this was a single-arm phase 2 study with a relatively small sample size, so the findings need validation in large randomized trials. Second, interpretation of pathological complete response data is challenging because many patients declined cystectomy. While the investigators incorporated repeat TURBT findings into their post-hoc analysis, we know from prior studies that clinical complete response rates does not always correlate perfectly with surgical pathology. Third, safety remains an important issue. Early in the study, 2 deaths occurred, including one treatment-related death from septic shock, which led to dose reduction and mandatory growth factor support. Although toxicity becomes more manageable afterward, the therapeutic window still needs careful evaluation. Another important question is where sacituzumab govitecan fits in the evolving treatment landscape now that perioperative enfortumab vedotin plus pembrolizumab has demonstrated very high pathological complete response rates, around 57%, and improved survival outcomes. And finally, the biomarker findings are hypothesis generating and require prospective validation before they can guide clinical decision making.
How can we implement this? You allude to it, the current state of the field, but how can this research be implemented or impact our current clinical practice and research?
It's a very good question. In the near term, in my view, this study is more likely to influence research than immediate routine practice. It reinforces the idea that antibody-drug conjugates can play a meaningful role in localized bladder cancer, not just metastatic disease. It also supports continued exploration of TROP2 targeted therapies either alone or in combination with other antibody-drug conjugates and or immunotherapy. The study may also help drive future biomarker-based trials, particularly using molecular subtypes or top1 expression to identify patients most likely to benefit. Another important implication is the growing interest in bladder preservation strategies. Patients increasingly want alternatives to radical cystectomy, especially when they achieve deep responses to systemic therapy. This study contributes to the ongoing discussion about whether selected patients could safely avoid surgery in the future. Overall, in my view, the work moves the field forward towards more individualized treatment approaches and supports integrating translational science into perioperative bladder cancer trials.
Very well said. Before we wrap up, can we just go over some of the key strengths and weaknesses of this study?
One major strength is that this trial addressed a clinically important and understudied population, patients who are cisplatin ineligible or decline chemotherapy. Another strength is the robust translational component. The study incorporated comprehensive genomic profiling and transcriptomic analysis, which provided valuable biological insights and generated potential predictive biomarkers. The study also included a relatively high-risk patient population, including many patients with clinical T3, T4 disease and variant histology, making the efficacy signals more meaningful. However, there are important limitations also. This was a small single-center, non-randomized phase 2 study. The lack of control arm limits definitive conclusions regarding comparative efficacy. The high rate of cystectomy refusal complicates interpretation of pathological complete response rates and makes comparisons with historical neoadjuvant trials more difficult. Safety was also a concern early in the trial, requiring protocol modification and dose reduction. Finally, the follow-up is still relatively short, and longer time survival outcomes are needed. Overall, though, the study is provocative and hypothesis-generating, and it meaningfully advances the conversation between ADCs and bladder preservation in muscle-invasive bladder cancer.
Well, thank you, Dr. Swami, for speaking about the JCO article, Neoadjuvant Sacituzumab Govitecan in patients with muscle-invasive bladder cancer, primary results of the SURE-01 trial. Join us again for the latest JCO simultaneous publications presented at the ASCO Annual Meeting 2026. Please take a moment to rate, review, and subscribe to all ASCO podcast shows at asco.org/podcast. Thank you.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.